Good afternoon. Thanks for joining us today for the presentation of hip arthritis and treatment. My name is Robert Maley, and I'm an orthopedic surgeon with Sutter Health's California Pacific Medical Center and Nevada Community Hospital. I'm in practice at the California Pacific Orthopedics and Sports Medicine here in San Francisco. You'll find my contact information in the speaker bio box on your console. Our format today will be a 20 to 30 minute presentation on hip pain and treatment, followed by questions and answers. I want to thank everybody for attending this seminar and taking time out of your day to talk about hip pain and arthritis, a topic that I'm very interested in. At the end of the presentation, I'd like to remind you to fill out our survey. As well, this will follow our question and answer period, which will also conclude at the end of the presentation. So if you're watching this webinar or listening to it today, there's a good chance that either you or someone you know has hip pain. In a survey conducted in 2006, in which 10,000 people were surveyed at random between the ages of 14 and 65, 22% of those people reported having significant hip pain. Additionally, patients over the age of 70, we find 20 to 30% of them have symptoms of hip arthritis. So for today, I'd like to help you understand the causes of hip pain, the potential non-operative and operative treatment options, what joint replacement surgery involves, and what you can expect following a joint replacement. Following this, I'll answer your questions as best as I can. First of all, the hip joint. What exactly are we talking about? Well, the hip joint is several things. It's a ball and socket joint, which consists of the socket, which is the acetabulum, and the ball, which is the femur. It's surrounded by muscles, ligaments, and tendons. When we look more specifically at the hip joint, this is a picture of the acetabulum, which is the cup portion of the pelvis. As you can see here that I'm holding up and shifting around, the socket itself forms the cup, and that's the acetabulum, which is lined with cartilage. Around the perimeter, which is not actually seen here on the image, but was on the previous slide, there's a soft tissue structure called the labrum, and we'll talk a little bit more about that in a minute. Also in this picture is the femoral head, and this comprises the ball of the hip joint. The femoral head itself is lined by cartilage. Again, we'll talk more about conditions that affect this. There are a variety of causes of hip pain, and these can range from simple sports injuries, falls and fractures, a condition called femoral acetabular impingement, and from arthritis. Sports injuries tend to occur in the younger patient population. They tend to be self-limiting and get better with rest, ice, anti-inflammatories, other medications if needed, and sometimes physical therapy. Falls and fractures are very common, especially in our elderly population, and this can lead to a fracture in the hip as well as a possible dislocation. This causes pain immediately and also can be a source of pain down the road. The conditions of femoral acetabular impingement and arthritis are going to be more talked about today in this webinar. We have to always be aware of referred pain into the hip. On occasion, you may be experiencing hip pain that's not actually from the hip or the soft tissue structures that surround it, but rather it comes from somewhere higher up, like the lumbar spine. There are two conditions in the lumbar spine that predominantly cause this, and that's spinal stenosis and a disc herniation. When you do see your doctor, they will look closely for signs and symptoms of these conditions. So femoral acetabular impingement, it's a big word. What does it actually mean? Well, how I best describe it, I think, is to think of it as a mismatch between the roundness of the femoral head and the roundness of the socket. One of these can be abnormal, or both of them can be abnormal. Also, too, the position of the socket can be slightly off. This can be a result of a childhood hip injury, or just simply the way that you were developed and the way that your hip was packaged. In the next picture and slide here, I'd like to show that subtle variations in your anatomy, whether small or large, and the conjunction of time can lead to degeneration of the hip joint. So what's that to say is, if the bony acetabulum is mal-shaped or formed abnormally, like in femoral acetabular impingement, in the active patient, with time, this can lead to degeneration of the hip joint. And this would tend to occur in patients younger than you would expect, like that occurs with osteoarthritis. This is a schematic of a normal hip and a hip with femoral acetabular impingement. On your left, you can see the hip has a normal range of motion with no significant abnormality, causing a pain-free wide range of motion. On your right, you can see the excess bony growth at the femoral head-neck junction limits the motion because that extra bone impinges against the labrum, or the cup portion of the acetabulum. With repetitive motions, this causes damage to the labrum and possibly the cartilage of either the femoral head or the acetabulum. It could also lead to a tear of your labrum. Now, how do you know if you have femoral acetabular impingement? Well, more often than not, you're going to have pain that's located in the groin. And when we see patients that have pain in the groin, that oftentimes correlates with a problem going on in the hip. So look for a sharp pain in your anterior groin, especially with activities that require deep flexion, such as cycling or prolonged sitting. There are several different treatment options that can be offered for patients with femoral acetabular impingement. First of all, you need to be properly diagnosed, and that includes having a good physical examination in which your physician looks specifically for this condition. If on your physical exam you have signs or symptoms that are consistent with this, he or she will most likely order an MRI. The picture on the left depicts an MRI of the right hip in which the patient has a tear in their acetabular labrum, which is depicted by the arrow pointing to this. If you're diagnosed with a tear of your labrum or the condition called femoral acetabular impingement, don't worry, there are several options that you have prior to considering surgery. And this would include anti-inflammatories, activity modification, rest from sports or the activities that are causing your symptoms, and possibly a cortisone injection. Some patients, this works and nothing further is needed. Now, if this doesn't work, there are other options, and that usually entails surgery. On the schematic here on your right, this demonstrates what an arthroscopy of the hip would entail. Arthroscopy of the hip is very similar to that of the knee, in which a camera is introduced into the hip joint to visualize both the acetabular cartilage, the femoral head cartilage, and the labrum. If there is a tear in the labrum and it's repairable, your orthopedic surgeon can repair it. Sometimes, however, it needs to be debrided. During that procedure, some orthopedic surgeons are also able to adjust the contour of either the socket or of the femoral head-neck junction to prevent from further impingement in your lifetime. Now, on occasion, that's not always possible, and sometimes patients have a little bit more severe impingement, either due to, again, an abnormally rotated socket or more significant deformity in their femoral head-neck junction, and this could require a larger procedure. This comes in two formats. One is a mini surgical decompression where an incision is made in the front of the hip. The area of interest is exposed and is shaved with special instruments. In more advanced cases, a larger procedure is done where we can reorient the bones of your pelvis to prevent the impingement from occurring. Arthritis tends to be the most common problem that patients have that leads to hip pain, and there are a variety of forms of arthritis. Symptoms of arthritis can cause pain and stiffness. They can develop slowly or very suddenly. They sometimes can cause swelling, and most all of them cause problems with daily activity, making simple tasks hard to do. Pain from an arthritic joint can be constant or intermittent. It can occur with movement and be worse with certain activities. It can also be worse after a period of rest. Some folks will notice that they're having pain in their hip joint during certain times of the day and with certain specific activities. Also, too, it can be worse with activities, especially impact activities such as running. How do you know if you have hip pain? Well, you should ask yourself, do you feel like you limp? Do you have problems going up and down the stairs or taking on or off your shoes? Can you get in and out of a chair easily? Have you noticed that one leg is getting progressively shorter over time? Also, are you noticing pain in the front of your groin, the side of your hip, or the back towards your buttock? On the rare occasion, sometimes patients will have pain referred down into their knee, and they won't even experience any pain in their hip. In fact, they have an arthritic hip, and because of the arthritis in the hip, it's irritating one of the sensory nerves that innervates the anterior part of the knee or the front of the knee, and that causes knee pain. Several times we'll see patients that have come in that have been treated for knee pain with cortisone injections or anti-inflammatories, even a knee arthroscopy, looking for a problem in their knee, but really it's the hip. So if you do have knee pain and no hip pain, usually your doctor will examine your hip just to make sure that that's not the cause of your problem. Lastly, Does the pain awaken you at night? If the hip pain or the pain that you're experiencing from your hip arthritis awakens you at night, this is a pretty good indicator that your symptoms are fairly advanced. There are various types of arthritis. Osteoarthritis is probably the most common cause of arthritis, and that can be simply viewed as a wear and tear phenomenon, where the cartilage, for either the reason that we don't know or a misshapen acetabulum and femoral head, leads to progressive and slow deterioration of the cartilage to a point when you're bone on bone. When that happens, that causes significant pain, stiffness, and limitations with your range of motion and activities that you enjoy doing. This commonly affects patients over the age of 50 and sometimes runs in the family. So if your mom or your dad, your brother, your sister, or your grandparents had symptoms of arthritis in the past, there's a good chance that you may have it too. On occasion, patients can have arthritis in their hip and then eventually develop arthritis in their knee or other joints too. So if you have a history of arthritis in your knee, it might not be unexpected that you could develop arthritis in your hip. Other conditions listed on this slide are also causes of arthritis. There's an inflammatory group of arthritis, which the most common cause is rheumatoid arthritis. In rheumatoid arthritis, there is abnormal thickening and inflammation of the lining of the hip joint. That causes chronic pain and slow deterioration of the cartilage. Other conditions such as avascular necrosis and post-traumatic arthritis I'll touch briefly upon in the next few slides. Lastly, some patients had a problem with their hip when they were born, and that required either surgery or casting. And again, due to the abnormal development of their hip socket and or femoral head, this led to abnormal mechanics which accelerated the wear of their hip joint, eventually leading to deterioration and arthritis. Osteoarthritis, again, the most common type of arthritis. This is an x-ray of a patient that has an arthritic right hip. The right hip is labeled with the R, the left hip is labeled with the L. And if you notice, if you look carefully, there's a significant difference between both hips. On the right side, you'll notice that there is no joint space. And that means that the head of the femur is rubbing on the socket. You'll also see that it looks kind of brighter, it looks more white. And that's due to hardening of the bone in response to the bone-on-bone rubbing. You'll see bone spurs that have formed, and you can even see some cysts that are forming in the bone. All of that is a reaction to the arthritis. If you look careful enough, too, you'll notice that the right leg is slightly shorter than the left. On the left side, there is no evidence of significant arthritis at this time. The hip joint looks well preserved. There are no bone spurs. In the condition called avascular necrosis, for whatever reason, some are known reasons and some are unknown reasons, patients develop problems with blood supply to the femoral head, and that eventually leads to death of the bone in the femoral head. The schematic on your left is a drawing depicting that, and where it says flattening of the top of the femoral head, this represents a severe case, or rather advanced case, of avascular necrosis. The blood supply to the bone has stopped essentially, and the bone has died. You no longer have that nice sphere, and it's now collapsing, and it leads to an x-ray like you see on the right, where there's significant collapse of the femoral head. And as you can probably imagine, this is extremely painful. Once the femoral head collapses, there is very little that we can do to help manage patients with this. Now, if you're in that stage where the femoral head has not collapsed, there are some things that can be done, and you should speak to your orthopedic surgeon more about those. There are a variety of things that can cause avascular necrosis. Also, too, sometimes it just develops. So this is another discussion that you should have with your doctor, because it's a longer discussion, and based on each individual, it's different. There's also a condition called post-traumatic arthritis. If you remember in the beginning of the presentation, I mentioned that falls or fractures around the hip can cause significant hip pain, and that seems pretty obvious. This is a patient of mine who sustained a fall years ago, and the x-ray on the left is her fractured femoral neck. She underwent surgery for stabilization of that fracture, and that's depicted on the right. You can see that there's 4 screws that were placed across the fracture site once the hip was realigned. She did well initially. However, over the subsequent years, the fracture did not heal properly, and a lot of that's due to compromised blood flow to the femoral head. And now you can see that the screws look like they're backing out, but really what's happened is the fracture is shortened. One of the screws is almost going through the femoral head, and we're starting to see signs of bone spurs forming around. The patient had significant pain when I first met her and had a hard time walking. And unfortunately, the only option in this circumstance is to do a total hip replacement, and this is her hip replacement seen on the right. Treatment options. There are a lot of treatment options. If you're experiencing hip pain, whether it's a sudden onset and you've had it for 1 week, 1 month, or 1 year, or even more than 1 year, there are a variety of things that we can do to help you out. And I recommend going in stepwise progression. You can always go forward and try something different. If you jump at surgery and you jump too soon, it's hard to go back. One of the first lines of treatment is to avoid activity modification. So you want to avoid things like standing in line, or prolonged walking, or prolonged standing. If you go to the DMV, you probably frequently experience this. Stairs are very difficult. And if you have to climb several flights of stairs, sometimes it's better to take the elevator. Lifting heavy objects also can exacerbate the pain. And sporting activities that aggravate your symptoms should be avoided. The next line of therapy that we have are medications. One of our first lines of medications are non-steroidal anti-inflammatories. You've probably seen a lot of these or commercials for a lot of these, and these include Motrin, Aleve, Advil, something called diclofenac, Celebrex. There are a variety of these out there on the market, and all have different efficacy. The anti-inflammatory medications are oftentimes taken 2 or 3 times a day. I recommend that you take them with something to eat because they commonly upset your stomach. If you have an allergy to certain anti-inflammatories, or if you're on something like Coumadin or a blood thinner, you may want to avoid taking the anti-inflammatories as you're at an increased risk to cause bleeding in your stomach, and that would be a bad thing. Patients that have an allergy to an anti-inflammatory or that are on Coumadin, I'd recommend you try something like Tylenol or try another form of pain medicine. Some patients' hip pain is so severe that they have to take something stronger, and that would include tramadol, which is not a narcotic medication, or some other type of medication that falls in the narcotic category. Patients that are on the narcotic form of medication are having significant pain. What other options are there? Well, your physician, if you're having hip pain, may have recommended physical therapy, and for good reasons. Physical therapy helps reduce stiffness and keep the joints flexible. It can also teach you isometric exercises to build muscle strength around the hip. I frequently recommend patients to try physical therapy for 2 reasons. One, if you can build up the muscles around the hip joint, it actually helps kind of cushion the joint itself. The stronger your muscles are around your hip or your knee, the longer your joints will last. Also, too, patients that have had physical therapy prior to surgery tend to have a quicker recovery post-operatively. So sometimes, even with the patients that have bone-on-bone arthritis, we'll recommend that they attend physical therapy as a sort of pre-rehabilitation or pre-operative rehabilitation phase to help get them to expect what's going to happen after surgery and to get stronger before the surgery. Another line of non-operative treatment are cortisone injections. Cortisone is a very strong anti-inflammatory drug that can be delivered directly into the hip joint. It's a concentrated dose that stays in the hip joint. If you have diabetes, it may cause a slow elevation of your blood sugar, but that's very brief and transient. It usually has no significant systemic effects. The injection is both diagnostic and therapeutic. So sometimes if I have a question if the patient that comes in with hip pain is having pain from their hip or is it coming from somewhere else, I'll recommend a cortisone injection because it's diagnostic in the sense that it will tell me right away if the pain is coming from their hip. If they get better right away, that's usually due to a local anesthetic that's combined with the steroid and injected into the hip, which essentially numbs up the hip joint. Now, that anesthetic will tend to wear off in about 8 hours. So sometimes patients will wake up the next day and say, God, I had great pain relief after that injection, but now I'm waking up and it feels like you gave me the flu shot in my hip. I tell them that's very normal. And in fact, it actually may take 1 to 3 days before the steroid starts to kick in, so to say. Now, in patients with very, very advanced arthritis, sometimes the cortisone won't help. And all that they'll get is very temporary relief from the local anesthetic. And that's okay because what they'll feel after the injection is hopefully some brief relief, but they'll be assured that their pain is coming from their hip. A nice thing about cortisone injections are we can do them in the office. And again, they take about 2 to 3 days to start working. However, at the end of the day, despite physical therapy, anti-inflammatory medications, modification, activity modification, and steroid injection, if those all fail, there is truly only one cure for hip arthritis, and that is a joint replacement. There are two different types of joint replacements that are frequently done for hip arthritis. On your left is the example of a hip resurfacing. On the right is an example of a total hip replacement. I'm going to try to do my best to explain how these are done and what the components are, and actually show you some examples here. What is the goal of a hip replacement? Well, the goal is simply to relieve your pain and restore your function, and get you back to doing the things you want to be doing. The incidence of hip replacement is dramatically on the rise, and a lot of this is due to our baby boomer population that is very active and wants to stay active. By the year 2030, we're expecting a 200% increase in the number of procedures done annually. That means roughly 570,000 total hip replacements or hip resurfacings done in the United States alone. Did you know that the first total hip replacement was actually done in Germany in the late 1800s? Now, it's much different than those that we do today. The first total hip done in the United States was recorded roughly in 1940. The modern day principles of total hip replacement were developed in the 1960s and 70s, and we utilize many of those principles still today. Of course, our implants are a little bit better, and our hip replacements are lasting longer. It's been termed the operation of the century, and it's actually very true. It's one of the most successful procedures done in all of medicine. It provides predictable and often dramatic functional improvement and pain relief. You may say to yourself, but I'm either too young or too old for a joint replacement. And really, a joint replacement should be a decision that you have with yourself, your family, your orthopedic surgeon, and your primary care provider. Age should not be a limiting factor. I've seen joint replacements done on patients in their teenage years all the way to their 90s. Once you say to yourself, you choose surgery, what are you getting yourself into and what does this involve? Let's try to go through that on a stepwise progression. First of all, what is a total hip replacement? Well, in a hip replacement, the hip socket is replaced with a metal cup and a liner. The femoral head, the ball, is actually cut off and replaced by a metal stem that has a ball on top of it. This is showing a depiction of what is actually done. So, intraoperatively, once the hip joint is exposed, we use our instruments to remove the femoral head. This here, if you can see, is a representation of what that looks like. I'm going to put them side by side so you can maybe get a better idea. So, obviously the one with the head is before it was removed, and this is what it looks like after removal. Now, I'm going to point the femur towards you. You can see that the femur is kind of a hollow cylinder. We use special instruments to prepare the center of the femur to accept the metal stem. On the picture on your right, you see what one of those metal stems looks like, and I'm going to show it to you in a little bit more detail here. You can see that I can hold it. It's actually fairly light. I'm going to rotate it around to get a better idea. There's actually kind of a porous coating on this one that goes circumferentially around it. And what that's used for is for your bone to grow onto this prosthesis. I'll show you how we insert it too. So, with the femur exposed and after it's been prepared, using our special tools, we simply slide it in, and this is what it looks like. Now, once that portion is done, we'll attach a metal head, ceramic head, or an oxinium head. And this is what the hip replacement there looks like. That's the femoral side of the operation. On the other side, the socket side, it's prepared in a very similar manner. So again, here's our pelvis. Here's our socket. Once that is exposed, we use special instruments to remove any of that cartilage that remains from the socket. And then we insert our metal cup. Sometimes this is press fit. In the past, it used to be cemented, but more often than not now it's press fit into the cup. Your surgeon may choose to add extra fixation in the form of screws, which would actually go into these holes in the metal socket. Now, once that's completed, your surgeon will insert a liner. Okay, there are various types of liners that can be inserted. This is a plastic or a polyethylene liner, and this is what it looks like once it's assembled. So essentially, the hip replacement has 4 components. You've kind of seen a progression of them there. Again, the femoral stem, the ball, the liner, and the cup. And when it comes together, it looks something like this. Are there options for bearings? And the answer to that is yes. There are many different options. Hip replacements are what we call modular. It means there's a lot of working pieces. And the whole idea for that is it allows us to kind of customize the hip replacement to the patient. We can use larger head sizes. We can use different types of materials. We can also change the different types of femoral components and their offset or their neck length to help match your normal or your leg length that you had prior to surgery, so that that's not an issue for you. In terms of the bearing itself is actually the head and the liner, okay? And there are a lot of different options. You have metal on plastic, ceramic on plastic, ceramic on ceramic, a new type of ceramic or ceramic equivalent called oxinium on plastic, or metal on metal. Next, what is a hip resurfacing? Well, a hip resurfacing is not for everybody, and this is another conversation that you want to have with your orthopedic surgeon to discuss if this is a correct surgery for you. More often than not, these are reserved for people of the appropriate size. So it's something that's not too tall, not too short, that is usually a male in their 40s or early 50s that have good bone stock. It does differ from a hip replacement in terms of how we prepare the hip. So in a hip resurfacing, the socket side is very similar to that of a total hip. This is an acrylic model showing the cup for a hip resurfacing that gets placed into there, very much like the total hip one does. The difference is the femoral side. So this is an acrylic model of a femur that has been prepared specifically for a hip resurfacing. What is done is, using special instruments, we're able to shave off the cartilage surrounding the head and the neck, and then we glue in this cap onto the head of the femur. That then will, upside down, sorry, that will mate with the cup. So instead of having 4 working pieces, you have just 2 working pieces. If hip resurfacing is something you're interested, I would ask that you talk more with your orthopedic surgeon about it to learn the risks and the benefits of it. Again, this is a schematic that you can find on the Sutter website, which demonstrates the bony cuts and how they compare of a hip resurfacing compared to a total hip replacement. And in the hip resurfacing, you can see it, or you can kind of visualize it as a bone preserving procedure because the femoral neck is not cut and is retained. Again, these are what the implants look like, and that's the acrylic model that I just showed. Which one is best for you? Well, we're all different. We're all of different ages, shapes, sizes, and activity levels. So again, having a discussion with your orthopedic surgeon in regards to hip resurfacing or hip replacement is something that I would recommend that you do. In addition, I would look into the different types of bearing options, because you do have a choice at the end of the day what you have placed for your hip replacement or your hip resurfacing if you so choose that. So what is making hip replacement today so successful? Well, it's a comprehensive approach that begins preoperatively and extends into the postoperative phase. It's also a collaborative effort. This is not just based on the work that your surgeon done, but it has a lot of different facets that goes into it. And that includes your anesthesiologist, the surgeon, the physical therapist, the nurses on the floor, the discharge planner. All of them work together to help give you the best outcome possible. We like to address pain management. We don't want you to be nauseous. We want to make sure that when you go home, you're going to be safe. Prior to hip replacement surgery, you do need to be seen by both your orthopedic surgeon and probably your primary care physician for your preoperative visit. There's a lot of planning that goes into this, including x-rays. I'm going to show you an x-ray that we take and what we do with that x-ray. In addition, you need to go through some routine blood work, a urine sample, a physical exam. We'll talk about exercise and if you should be doing any exercises differently than you're already doing. If you smoke, it's ideal that you stop, and you should also stop certain medications. I mentioned preoperative x-rays. Well, everybody, again, is different, and we try to restore your normal leg length. And what we do for that is we pre-op plan. So this is an x-ray showing a patient that had avascular necrosis. And what you can see is the actual template and plan that goes into this. You can see that we're trying to figure out what size the acetabular cup should be. We're also trying to see which size femoral component we can use. And based on which size femoral component we should use, we want to look and see where we should make our neck cut to give this patient the most optimal outcome. On the day of surgery, you're going to have nothing to eat or drink prior to coming to the hospital. And that usually starts for nothing to drink or eat after midnight. You're going to meet with your anesthesiologist and discuss different types of anesthetics. There are basically two different types of anesthetics that are used. One is the old school, which is a general anesthetic, and kind of the newer school is a regional anesthetic, where you get one shot of a local anesthetic into the spine to help numb up your legs. And your legs will be numb for several hours, and during the procedure they'll give you medication so you basically rest. Some people call this a twilight anesthesia. It's very effective. It has a lot of less side effects than a general anesthetic. If your surgeon or your anesthesiologist or your primary care recommend that you undergo a general anesthetic, then I think that's probably for certain reasons which may be related to your health, but that is okay. That's absolutely needed. Surgery itself takes about 1 or 2 hours. After that, you're transported to the recovery room where you recover from anesthesia, and then you're brought to the surgical floor. Physical therapy can happen as soon as 5 hours after surgery, and we have found that the sooner patients get out of bed, the faster they're going to move and the faster they're going to rehabilitate. Sometimes you may be a little lightheaded when you first try to sit up, and that's okay. In those instances, we'll get you up the next day after surgery. That's usually in the morning. Physical therapy is going to work with you on a daily basis, actually twice-a-day basis, and sometimes even more than that, to get you going. They're going to teach you how to strengthen your muscles, different range of motion activities to do, and most importantly, they're going to help you learn how to walk again. Depending upon the surgical approach that your surgeon uses, and depending upon their philosophy, you may have certain restrictions on different types of movements or activities that you can do. I like to have all of my patients follow some certain precautions in the first few weeks to make sure that they stay safe and that they protect the hip replacement that they work so hard to get. Also, too, I recommend that they use either a cane, crutches, or a walker to help them walk. More often than not, patients have no problems with balance, but if somebody was to fall, that would be a devastating type of event. I would rather have them use a cane, a crutch, or a walker for several days to several weeks until they feel safe. And that's going to be a decision made with both the patient and the physical therapist on when they can go from using one of those assistive devices to using nothing at all. Prior to discharge, we have certain requirements. We want to make sure you're going to be able to be safe when you go home. So we're going to ask you if you have anybody at home to help you out. We want to make sure you can get in and out of the bed by yourself, that you can get on and off the toilet or a bedside commode or simply a chair. You need to be able to walk 100 feet and walk a flight of stairs. It sounds crazy. You think, I just had my hip replaced. How can I walk stairs? I'll tell you, I've seen it. It can be done. There are certain patients that do physical therapy and are able to do stairs as soon as the evening of postoperative day 0, which is the day of surgery, or the next day. How long is your hospital stay? A lot of patients ask this, and I think it's a great question because you need to plan how long you're going to be in the hospital. Everybody is different. The historical length of stay used to be 1 to 2 weeks. In the beginning, they kept total hip patients in the hospital for a while. Now, these days we like to try to get patients out of bed, moving quicker. We're using different anesthetics and different forms of pain control, and we're reducing the hospital stay to anywhere from 1 to 2 or 3 nights. So the hospital stay is dramatically improved, and I do believe it's from different techniques that we use, different medications that we use, and from a better understanding of what works for patients and what is holding them up from going home. More often than not, it's not you, it's us. We've done something to you, such as giving you strong pain medicine, which makes you nauseous or drops your blood pressure and prevents you from working with the physical therapist. We're more keen to that, so we address that ahead of time. We try to make sure that your volume status stays up, which means to say that you don't get lightheaded or dizzy when you stand up. We watch what type of medications we give you to make sure that we don't sedate you too much and prevent you from working with physical therapy. And also, we're not scared to get you out of bed right away. In the past, patients used to lay in bed for several days because they were fearful. Nowadays, we show patients you can get up and you can walk. Everybody is different, though, and we have to keep that in mind. And so you have to look at each individual being different, and so will their speed of their recovery. We're not looking to send people home on the first day or the second day. we want to send them home when it's appropriate. What can you think of your estimated schedule being? Well, usually you'll be in the hospital for 1 to 3 nights, and then you either get discharged home or to a rehab facility. The patients that go to a rehab facility didn't meet those criteria to go home, and they just need more work with physical therapy, and that's fine. We anticipate that you'll be weaned or basically away from your cane or your walker within 2 to 4 weeks. We expect to return to driving anywhere from 2 to 6 weeks. If you drive a clutch or stick shift, or if it's your right hip that you're having replaced, you're looking more at 4 to 6 weeks. If it's the left hip, as long as you're able to get in and out of the car safely and you're not taking narcotics, you can pretty much drive between 2 and 4 weeks. If your surgeon imposed some hip precautions on you, we discontinue those typically at 6 weeks. We note maximal improvement varies with everybody. We're going to see some examples of this later on in the presentation, but you can expect maximal recovery in 3 to 12 months. With any surgery, there are always risks, and this needs to be a long discussion you have with your surgeon, because I think you need to understand there are risks to total hip replacement or hip resurfacing. As much as I am a fan of the procedure, I do believe that everybody should undergo a total hip or hip resurfacing understanding these risks. And these include dislocation potentials, which means that the hip actually pops out of the socket. And to show you back on our model here, what that would look like. Essentially, if you put your hip into an abnormal position, the ball can come out. Now, if that happens, it's easily treated. So I don't mean to alarm you. It happens very infrequently. And with the newer techniques and the newer materials that we're using, it happens in less than probably 0.5% of patients. Other complications or potential complications include a leg length discrepancy. More often than not, when patients develop arthritis, that joint space that they once had narrows. So if you think about it like that, if your joint space is narrowing because you're losing cartilage, your hip is going, or that leg is going to be a little bit shorter. Now, a lot of times this happens gradually over time, so patients don't even know that one leg is shorter than the other. Our goal is to put your leg back where it was. So a lot of times patients wake up and they say, hey, you've actually lengthened my leg here, huh? And we say, yes, we have. And that sensation, if you have it, tends to go away by the 6th week. On occasion, we do actually lengthen the leg a little bit more than what we consider to be normal, and that is to gain a stable total hip. So if for whatever reason your muscles around your hip were too weak, and intraoperatively we felt that a more stable hip would be leaving you with a little bit longer of a leg on that side, and again we're talking millimeters, or even maybe as small as 1/8 of an inch, we would elect to do that to give you a stable hip. That comes first. Infection is always a risk, and if that happens, it can be devastating. Blood clots are a risk, and those can be DVTs, or deep venous thrombus, which if they dislodge can go to the lungs, and that's called a pulmonary embolism. Speak to your surgeon and ask them what he or she does to prevent against those. Also, patients can have a fracture around the implant. That can occur at the time of surgery or post-operatively. And when I mean post-operatively, I mean anywhere from day 1 after surgery to 20 years after surgery. It's something that we have to monitor for. And if it does happen, it's dramatic and you would know it happened. Also times, people will have to have their hip surgery revised for one of a variety of reasons. The most common being the patient had a hip replacement 20 or 30 years ago and their bearing surface is finally worn and they need it changed. There are other reasons that can lead to a revision hip replacement. Again, a discussion to have with your doctor. There are also medical risks, and those include potential for blood transfusion, urinary tract infection, a pneumonia, a heart attack, or stroke. How long will your new hip last? Well, it's impossible to predict, and every individual is different. We do know that hip replacements that we've been putting in the last few years are lasting many years. So we tell people anywhere from 15 to 25 years. Things go into this, and that includes age, weight, and activity level. Can you be active after your total hip replacement? Absolutely. We want you to be active. The reason you're having the hip replacement is so you can return to your active lifestyle, which we fully support. This is a patient of mine who is an avid fan of yoga, and at every visit post-operatively, when I saw her at 2 weeks and 6 weeks, she asked me if she could return to yoga. I don't do yoga myself, so I said to her, can you help me out and understand what you would like to do? And she says, well, I'll show you. I said, wait, before you start doing any of these poses, let's wait until we're about 3 months after surgery. So she comes into the office with a list of different poses that she would like to do, and we went over them, and she's able to do them. This is her doing 3 of the poses that she was kind enough to send me pictures of. In addition, one of my partners, Dr. Callender, has a patient who is a tap dancer, and he was so pleased with his result, he sent in this video of himself tap dancing.
Hi, Dr. Callender. It's Lars Ross. 8 weeks after my surgery, you asked me
maybe
if
a
I
little
would
bit
send
slower
you
for certain
a
bandwidth
tape
on
me tap dancing, so I'm going to do that for you right now. This is a very gentle, easy, but very famous, historically significant tap dance.
That was my fault. I apologize for that. I accidentally advanced the slide too soon. Again, this may play a little bit slower for folks if your computer's bandwidth is slow.
Hi, Dr. Calendar.
And again, too, if you'd like to see this, you can't see
8
it. It is
weeks
on our
after
website,
my surgery,
surgery.com.
you asked me if I would send you a tape of me tap dancing, so I'm going to do that for you right now. This is a very gentle, easy, but very famous, historically significant tap dance, a soft shoe choreographed by Charlie Atkins and Honey Cole, called Take It a Chance on Love.
Where can you learn more? Well, there's a variety of resources. First of all, visit your doctor, either your primary care physician or an orthopedic surgeon, to have another discussion. Just because you go to the doctor doesn't mean that you're signing up for surgery, whether it be for femoral acetabular impingement or hip arthritis. But at least go and gain the knowledge of what is causing your symptoms. If you are a candidate for a hip replacement, or if that's something that looks like it's going to be in your future, you may want to attend a joint replacement class. Again, you're not signing up for surgery. You're just getting a better understanding of what does the hospital look like? What does the hospital room look like? Who are the physical therapists? What do they do to help you out after surgery? Ask a friend. Again, many people are having this procedure done today. I'm sure most of you know at least one person who has had it done. There are also a variety of online resources. You can click onto Sutter's orthopedic website, which is a link should be visible in your viewer. Other resources online, a simple Google search will help turn up a lot of those. There are even apps on iTunes that you can use to download. One is called Arthritis 411, where you learn more information about hip replacement. I want to thank you for taking the time to spend listening to me talk about hip pain and treatments for hip arthritis. This is a topic that I really enjoy because I believe in it. I believe if you have hip arthritis and you failed all the conservative measures, a hip replacement will greatly benefit you. I'm more than happy to talk to any of you on an individual basis, and my contact information is listed here. Please feel free to email as well. At this point in time, we're going to turn our attention to the questions. I do want to remind folks that there is an online survey that we'd like you to complete. So one of our first questions is, what are the treatment options for hip bursitis, and how long does hip bursitis last? That's a great question. Hip bursitis can affect people that have not had a hip replacement and that have had a hip replacement. What is it? Well, bursas are little sacs of fluid that are all throughout your body. They tend to be over bony prominences. If you picture your elbow as a bony prominence, you definitely have a bursa there. You have them in front of your knees. You have them on your hands. You also have them on the outside part of your hip. Looking again at our hip model, this is the greater trochanter portion of the proximal femur. Just basically means the top part of the thigh bone. The bursa itself lies right over here on the outside portion. It can become inflamed, and that can happen for a variety of reasons. Once it becomes inflamed, I see 3 different treatment options. The first is oral anti-inflammatories, some of the medications we listed previously. You end up taking those for probably anywhere from 2 to 4 weeks. The second option is physical therapy, and the point of physical therapy is to help strengthen the muscles around the hip. Strengthening the muscles around the hip greatly reduces the inflammation of the bursa. The third option is a cortisone injection. So with the cortisone injection, that tends to subside the pain right away. I recommend 1, 2, or all 3 of those forms of treatment. Once you've stopped treatment, they are very effective at relieving the bursitis. Okay, the next question is, a patient had a total knee replacement in 2011, and can that contribute to the hip pain that they're having now? Well, the knee replacement was just done 1.5 to 2 years ago, so providing that it is functioning well, oftentimes we don't see pain that refers up to the hip from the knee replacement. However, again, everyone's different and depends upon how you may have recovered after your knee replacement. Do you have good range of motion and good strength of the knee? The other possibility is that, as I mentioned before, osteoarthritis can affect more than one joint, so it's very possible that it's affecting your knee and it could be affecting your hip. I'd recommend seeing your doctor and getting an x-ray to look at the hip, as well as having he or she examine your hip. Okay, our third question today is, what method do doctors use today in terms of surgical approach, anterior or posterior? That's a great question. There's actually several different approaches to the hip. You can get to the hip from the front, the anterior approach, from the side, which is a lateral approach, or from the back, a posterior approach. Most surgeons, if you survey or poll orthopedic surgeons, still use the posterior approach. There are different philosophies regarding these approaches, and again, this is a conversation to have with your surgeon. I would recommend that once you find a surgeon that you're comfortable with, I would ask him or her what they are comfortable with. I don't think I'd ask a surgeon that does the anterior approach to necessarily do a lateral approach on you, or to have a surgeon that does the posterior approach do an anterior approach. You want to have them do what works best for them and what they see gives their patients the best outcomes. In some of the data, there is no difference on approach. Okay, our fourth question. The patient is 55 years old and has been recommended to have a hip replacement. Again, they're asking about direct anterior hip approach, and specifically if I perform this approach. I actually do the posterior approach at this point in time. I can do it through, I'm very comfortable with it and found outcomes to be very similar to that of a direct anterior approach, meaning that patients are walking in to clinic at their 6-week visit using no assisted device and back to the activity that they want to be doing. There are various surgeons that do it. I'd recommend, again, finding a surgeon that does it frequently if you're interested in it. Okay, the next question is, how does someone decide if it's time to see an orthopedic surgeon about hip pain? That's a great question. In my mind, if you are thinking to yourself that your hip is either bothering you daily or it's limiting you in what you want to do, I think it's a great time to see an orthopedic surgeon. A majority of the patients we see, we don't operate on. Instead, we are basically having a conversation with them to better understand what's going on in their life and try to pinpoint what's causing the hip pain. If it is arthritis, then that's something that we can get to and deal with. So if it's bothering you enough, I would definitely recommend seeing your doctor. Our next question. The patient has mild arthritis in their hips and their lower back. Their walking is bearable in the hips, but they get severe pain in the back after walking a short distance. Is this related to hip arthritis? It very well could be. I'd recommend getting an x-ray of both your hips and your lumbar spine to further investigate this, as well as to have a conversation with your doctor about other symptoms that could be related to problems with your lumbar spine, such as pain that radiates down your leg, numbness or weakness in the leg. It's very possible that it's coming from your hip arthritis because your hip joint is stiff, and if your hip joint is stiff, it's going to affect the joints above and below it, as well as adjacent to it. So that means your other hip, your low back, and your knee. Okay, our next question is, someone's had pain for 3 to 4 weeks. What kind of self-help can they do? That's a great question. Pain that's been going on for 3 to 4 weeks, depending upon how old you are, first of all. If you're very young and it was related to a recent soccer event that you were doing, I would recommend doing the conservative forms of treatment, which include activity modification, which means stop doing the things that make the hip bother you, taking an anti-inflammatory, and that can be an over-the-counter. Again, there are many: Aleve, aspirin, Advil, Motrin, icing the region, and possibly seeing physical therapy. If you are a little bit older and it wasn't related to a specific event, it's just been a nagging pain, I recommend seeing your doctor if it doesn't get better and if those previously mentioned treatments don't work, so they can evaluate you, which would include a physical exam and an x-ray to see if you fall into the category of one of the previous causes that we mentioned for hip pain. The next question involves the person's having pain, is having inflammation of the muscles around the hip joint. How can they increase their mobility in their hip joint so that they can participate in dance, which is primarily ballet and yoga? That's a great question. First of all, for the inflammation, there's several things to do. Again, anti-inflammatories and ice. To strengthen the muscles around the hip, there are a variety of activities, and the primary muscle group that you want to strengthen is your abductors, and that's spelled A-B-D-U-C-T-O-R-S. The abductors of the hip are very crucial. As well, you can work on the other muscles of the hip, including the quads and your gluteus maximus as well. To increase your mobility, if the self-exercises that you're doing doesn't help, you could see a physical therapist and they can help you out with that. And our next question, somebody wants to know, is squatting bad for your hip? Squatting is not bad as long as it doesn't cause you pain and as long as you're trying to do it with good technique. I'm not sure if you're referring to squatting without the use of weight or with the use of weight. If it's with the use of weight and you're comfortable with it and you're comfortable with your technique, it's fine. When you squat, you put your hip into a pretty good amount of flexion. If you look at our model here real quick, so this is our hip joint, the native hip joint, and when you're squatting, you end up bringing the hip up. So sometimes that can cause that abnormal impingement of the femoral neck on the acetabulum, and if you have a slight abnormality, that could be a problem and cause pain. So if it's causing you pain, I would back off. Okay, our next question, looks like someone's suffering from acute hip pain due to arthritis, but they're on Coumadin. What pain relief measures are available in your case? That's a great question. There's a lot of patients that we see that come in on blood thinners, whether it's Coumadin, something called Xarelto or Pradaxa, for whatever reason they may be on it, whether it's a condition that they've had blood clots in the past or problems with their heart. Coumadin or any blood thinners does just that. It thins your blood. If you take an anti-inflammatory, you have an increased risk for bleeding in the stomach. If you're on Coumadin, that greatly enhances that risk, and so we advise that you don't take it. There are some medications that are helpful, such as Tylenol and Celebrex, which you may be able to take. I would recommend speaking to your primary care physician further to see what medications they would allow. And our next question, one of our viewers wants to know, is metal on metal bad? And that's a great question. A lot of folks probably have seen some articles in the New York Times, the Wall Street Journal, talking about failed or recalled components. So metal on metal is a very hot, controversial topic these days. I can tell you that not all metal on metal is considered bad. Some folks with the hip resurfacing and certain implants for hip resurfacing, specifically the BHR, have a great track record. It's not necessarily the bearing where the metal cap rubs on the cup that can be a problem, as much as in some designs, there's actual design flaws of the cup, which led to early failures of those. So if you're going to have a metal on metal implant, I would strongly advise that you look into it, you look at the options, and you talk to your doctor about the risks of it, and you want to know the track record of the implant. I recommend for anybody that's going to have a total hip replacement or hip resurfacing that they talk to their doctor about the bearing, because it's a very important topic. The next viewer's question is, their diagnosis is bone on bone. What are your options? A lot of folks come in saying that. We get an x-ray and we see bone on bone. And really I say, when I look at a patient with bone on bone arthritis, I think there's three important things. The history, so what you're telling me about your symptoms, your physical exam, and your x-ray. First of all, I want to know about your pain. Are you having pain all the time? Is it limiting you? Can you not walk anymore? Have you tried taking anti-inflammatories or injections? If you haven't tried any of that, despite being bone on bone, you may still have a lot of time before you actually need a joint replacement. Just because your x-ray shows bone on bone arthritis doesn't necessarily mean you should jump out of hip replacement. It should be a combination of your x-ray, your range of motion, as well as how much pain are you having. I think when patients have pain that wakens them up at night, it's a pretty good indicator that they're having significant hip pain. And the next question, the viewer's having pain when they lay on their side. What could this mean, and are there any recommendations? One of the common things that I see when patients say this is they'll actually have trochanteric bursitis. And again, when they're laying on their side, again, back to our model, so here's that bursa. If it's laying against the hard bed, it's causing an irritated bursa to be painful. Some simple things to do: try lying on the other side, try sleeping on your back or your stomach. And again, if that's not working, try taking an anti-inflammatory for a short period of time to see if that helps. If that doesn't work, I'd see your doctor. Okay, in the next question, the viewer would like to know, are cortisone injections effective, or how effective are they as well as are TENS units effective to obtain pain relief and even delay eventual total hip replacement? I answer that yes. I don't routinely use TENS units, but I do utilize cortisone injections. And again, for the reasons mentioned in the talk, which is that they're diagnostic and they're therapeutic. One, they let us know that your pain's coming from inside your hip joint, and two, it can buy you time before you need that total hip replacement. I would not recommend doing multiple injections in the hip if you find they're giving you less and less pain relief. I think at a certain point in time, there's a greater risk of continuing to do the injections. And again, this will be a conversation you have with your doctor. Okay, in the next one, a viewer wants to know that hip dislocation is a possible problem after joint replacement surgery. How common is this occurrence, and how can this be prevented? Great, great question. Okay, so first of all, how common is it? Well, this used to be much more common. There used to be reports of patients having dislocations or hip dislocations, in the 5 to 9%. That would mean 5 or 9 out of every 100 people are having a dislocation in their lifetime, which we found to be very unacceptable. So there are several things that we are doing differently these days to prevent against that. One of it is our job. It's the placement of the components. And so when people ask, they're thinking of having a hip replacement done, can anybody do it? Yes, for the most part, any orthopedic surgeon can, but I would recommend going to somebody that does these routinely, because more often than not, they're used to placing these components and looking for subtle anatomic variations in a patient that allows them to place the components accurately to prevent against dislocation. Also, too, we're using modular components, which means we can change the head and the neck length to help optimize your stability. So larger head, meaning a larger diameter of the femoral head, will lead to less dislocation. The dislocations today are much, much less. It's less than 1%. In a lot of series, that ranges from 0.2% to 0.5%. Hopefully that helps you, and if there's any further questions, please feel free to contact me in regards to that one. Also, too, on the liner side of our replacement, we have special things we can do where we can put an elevated liner to help prevent against dislocation. Okay, the next viewer is 43 years old and has been having pain for the past 6 months, and they have a popping and clicking sound when they walk. This is a great question, and this is nothing that I touched upon in the talk, but alluded to very quickly, and that is a lot of times patients can have pain coming from the muscles around the hip. So when they walk, if the muscle is tight or the tendon is tight, as it slides over the bony prominence of the hip, or basically just the bone of the hip, it can catch and snap or pop. So sometimes it's coming from outside of the hip joint, okay, and that would be one of the muscles or the tendons. Very infrequently, it's actually coming from inside the hip joint. And if that's the case, then we would recommend different treatment options, but first a conversation with your doctor to determine if it's coming from within inside the hip or out. So this is going to conclude our question portion of the webinar. Again, thank you for your attention, and I do strongly encourage you to fill out the survey, which is on your screen. Again, thank you for your attention, and